Welcome to Black Health Matters. I'm your host, Daryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
How to improve your memory by taking foods that have choline in them because the brain needs them. And it lists a number of the foods that are top sources of choline. And it starts off with salmon, broccoli, red potatoes, kidney beans, cottage cheese, yogurt, eggs, beef sirloin, liver, turkey breast, and chicken thighs, and some of the foods that contain a lot of choline, which is part of the acetylcholine that your brain actually requires. Just thought I'd share that with you, and I guess we can get started with the articles unless somebody has any questions about that.
No.
How do you spell choline?
Choline.
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 Thank you.
It's part of the acetylcholine that are involved in all nerve transmissions. Acetylcholine. John, I guess there's some reason that you decided to put this in since this is not Black History Month.
Yeah. We had talked about this actually a while back, but I thought it would be a really good opportunity to focus on some of your history today. And this was from, as you can see, from last year, but we really didn't talk about it. So I want to talk about it today. And this is a focus on you, Dr. Clive O. Callender. And this was featured at his church, Asbury United Methodist Church. I just thought it was really a beautiful tribute to you and all of your work, all your unselfish dedication to humanity. And I'm going to read the biographical sketch, and then you can take over if that's okay with you.
Your wish is my desire.
So Dr. Clive O. Callender is a pioneer known for his remarkable achievements in the field of transplantation. During his distinguished career, Dr. Callender spearheaded the opening of our nation's first minority-directed transplant center, founded the first national organization focused on eliminating the minority organ donor shortage, and advocated for policies that would lead to more equitable organ transplant rates. By the way, we've got someone who is not muted, and the noise is coming over the recording. So you try to unmute, try to mute everybody. Currently professor of surgery at the Howard University Hospital of Medicine, Dr. Callender is a native of New York and was educated in the city's public schools and colleges. After obtaining his bachelor's degree from New York's Hunter College, Dr. Callender went on to graduate work from Meharry Medical College in 1963 as the top-ranking medical student in his class. He proceeded to complete his surgical training at Freedman's Hospital, that's right here in Washington, D.C., in 1969. Next, Dr. Callender pursued his lifelong aspiration to become a medical missionary by volunteering in Africa between 1970 and 1971 during the Nigerian Biafran War. Upon his return, Dr. Callender joined the University of Minnesota for training in kidney transplantation under the renowned surgeon Dr. John S. Najarian from 1971 to 1973. Dr. Callender then returned to Washington, D.C., and developed the first minority-directed dialysis and transplant center and histocompatibility and immunogenetic laboratory in this country at Howard University. Eager to expand the services at Howard's Transplant Center, Dr. Callender traveled to the University of Pittsburgh for training in liver transplantation under groundbreaking surgeon Dr. Thomas E. Starzl from 1986 to 1987. The programs at the University of Minnesota and the University of Pittsburgh were two of the premier transplant training programs in the United States. When he began his work in the transplant area, African Americans were more likely to die waiting for an organ transplant and less likely to become organ donors. Today, African Americans account for the highest percentage of organ donors among ethnic minority populations. In 1991, a 1991 article in the New England Journal of Medicine chronicled the 10-year experience of the first national organ tissue donor program in America. Originated by Dr. Callender, the National Kidney Foundation of the National Capital Area and the Dow Chemical Company program helped triple both the number of Black Americans signing organ donor cards and the number of Black Americans aware of the successful nature of transplantation. Utilizing what he learned from these efforts, Dr. Callender conceptualized and established the National Minority Organ Tissue Transplant Education Program, MOTEP. This unique national program uses methodologies shown to be effective at reaching the Black community and applies them to all ethnic minority populations. National MOTEP is the first national organization to identify a twofold solution to the donor shortage: disease prevention and increasing donation rates. National MOTEP has been awarded total funding in the amount of $16 million from the Office of Research on Minority Health, now known as the NIH Institute for Minority Health and Health Disparities, and the National Institute of Diabetes and Digestive and Kidney Diseases, NIDDK, for program expansion. This innovative organization launched National Minority Donor Awareness Day, NMDAD, in 1996. By 2012, this effort was expanded from one day to a full week with the support of the Association of Organ Procurement Organizations, AOPO, and the Association of Multicultural Affairs in Transplantation, AMAT. As of 2020, the entire month of August is nationally recognized as National Minority Donor Awareness Month. National MOTEP's methodology has contributed to the national increase in minority donation rates from 15% in 1990 to 30% in 2008. In addition, a review of the United Network for Organ Sharing, UNOS, database between 1990 and 2010 confirmed a dramatic rise in donation rates among Black Americans. In fact, the number of African American donors per million exceeds whites and other ethnic minority populations by 2010. Remarkably, the number of African American donors per million increased from 8 in 1982 to 35 in 2010, reaching a high of 41 in 2018. Dr. Callender also established the MOTEP Export Research Center of Excellence, focused on eliminating minority renal health disparities via telehealth programs in hypertension and diabetes. The research center also examines neuroimmunological, say that twice, issues that lead to renal disease. In addition, the center developed a model for overcoming the devastating impact of institutionalized and environmental racism in end-stage renal disease. In 2021, National MOTEP celebrated 35 years of educating communities and saving lives through organ and tissue donation and transplantation. 1995 until 2008, Dr. Callender served as chair of the Department of Surgery at Howard University Hospital. In February 1996, he became the first LaSalle D. LaFalle professor of surgery at Howard University College of Medicine. Dr. Callender has received honorary Doctor of Science degrees from Hunter College in 1994, Meharry Medical College in 2008, and Howard University in 2014. As the country's senior African American transplant surgeon and expert, Dr. Callender has made hundreds of media appearances, including on the Oprah Winfrey Show, CNN News, and CBS Evening News. A skilled orator, Dr. Callender effectively addresses both professional and lay audiences and has done so at more than 1,000 meetings and forums. In addition, he has authored more than 150 scientific publications. Dr. Callender is proudest of two national awards he received from his efforts to increase minority donation rates. The 1997 Medal of Excellence from the American Association of Kidney Patients and the 2021 Pioneer Award from the American Society of Transplant Surgeons, the organization's most prestigious honor. While Dr. Callender has received many accolades and awards for his substantial contributions to medicine and health equity, his life's goal is to be remembered as a God-fearing surgeon who reached the unreachable stars. Dr. Callender, I turn it over to you. You can talk about these.
Okay, thank you. This is a picture of me when I finished in 1969. This is me over here when I had hair and a mustache.
Is that you right there?
That's me right there, yeah. And these are my colleagues, Rupert Lewison. I'm sorry, Rupert Lewison and Teddy Oswald Warner, and uh, these are the residents who were below me. You can go to the next one. Yes. This is probably one of an excerpt from one of my most favorite articles that I've done by Harriet Jackson Skarupa, saying that God should have the glory for whatever success I've achieved. You can see those were the days when I had black hair too. This was published in the New Directions. And this is let me go back to the other one you passed. Yeah. Okay. All right. The next one. Okay. And this is the installation ceremony at the National Academy of Science in 1996 when I was installed as the first LaSalle LaFalle Chair of Surgery. Go to the next one. And this is uh, the delivery of Antoine Braxton, who now is, I guess he's almost 50 years old now. This is when he was born from his mother, Vernita Howard, who subsequently died. This is his picture now. He's quite a guy now. At the time, this was the first first transplant recipient, one of the first to deliver a baby. I told her at the time that it was risky for her to have a baby because it might cost her life, but she said it was worth it. And so she went ahead and she kept her kidney for about 13 years and died of a subarachnoid hemorrhage, a brain hemorrhage. This is the time of the delivery, and this is our celebration. Next slide. Oh, this is me in Africa with our team and hospital baby. Uh, this is something that my wife and I did in 1970 and 71. And this is the whole team. And this is me. You can see how slim I was at the time. And it's my wife who So together we went. It was a tremendous experience. I did many surgeries, some very revolutionary and some very uh, common. This is this is me in Port Harcourt, Nigeria, which is where I did that, and uh, that was before I went into transplantation. And I actually decided against continuing my work as a medical missionary because I lost 50 pounds and felt that it was safer for me to continue my work in the United States with people of color. Uh, this is after we left Africa. My wife and I toured Europe. We were in Greece here. Probably my favorite picture of all with my wife in Greece. And then this is when I we were in Rome, Italy, with the Transplant Society meeting, and I got a chance to meet Pope John Paul in Rome, Italy. Uh, there's a picture I have in my house today. Uh, this is an article that heralds us performing the first liver transplant in the District of Columbia. That was the front page of the Washington Post, which uh, was beginning of the Liver Transplant Center. Not too often Howard University gets the front page. This is the United States Virgin Islands article that Betty Dillon and I worked with in the 1980s with Dr. Roy Snyder, who was the governor at the time. And this was pictures of the many operations. We did about 25 transplants down there, which was quite an experience that was great for everyone concerned, the United States Virgin Islands, and also Howard University. And it was a great opportunity to share our experience with the Virgin Islands. This is Senator Brooke, who was the one who actually allowed us to get funded as a transplant center. We started our first surgery in 1974, but didn't get funded until actually 1975. And this was all due to the intervention of Senator Edward Brooke III, uh, who made it possible. Next slide. This is some of the articles that newspapers did uh, uh, talking about Dr. Lee's search for Black donors as we went all across the country, uh, educating people about the need for Black donors. And it was a crusade that I'm thrilled to have been part of. Next slide.
Dr. Callender, Dr. Atto has his hand raised. He might have a question about the African.
Yeah.
Go.
Hello.
Hi, Doc.
Hello. Good morning. Do you remember the hospital you were?
Port Harcourt General Hospital.
Pardon me.
Port Harcourt General Hospital
Okay. 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 Thank you.
in Port Harcourt, Nigeria.
Okay. I thought it was Shell Hospital
No,
in Port Harcourt.
no, Shell was in Port Harcourt also, but
Yes.
Shell was particularly for those people who worked for the oil industry. This
Uh,
was
not, n-
this
not,
was the
not,
Port Harcourt General Hospital that was for
yeah.
everyone else.
Okay. Shell was, yes, for people who work for Shell and for the rich people. Yeah.
Yeah, okay. Yeah, that's right. That's accurate.
Mhm.
Okay, this is an Ebony article that was one of the first articles that talked about our work at the Howard University's Transplant Center. Uh, and it was done in 1988, heralding the work that we started in 1974 with our first transplant. Next slide, please. This is a Jet Magazine article. We had a number of articles in magazines and newspapers during those times that uh, talked about the work that we did at Howard University and the people we helped uh, over time. We also, of course, gave the 5 reasons why Blacks didn't donate, and also the strategy that we used for overcoming those uh, reasons for not donating. And this is part of the way in which we educated and empowered communities to become part of the solution to the transplant organ deficit.
I wanted to
Next.
interject, Dr. Callender. Uh, you are the reason in this campaign that you were involved in, coming to the NIH and doing a lecture at the Lipset Auditorium, where I saw you for the first time, and I was inspired to become a donor at that lecture. And right down the hall from Lipset is the Department of Transfusion Medicine, where I started to donate blood, even though I hate needles and afraid of needles. And I became a blood donor, and this was in 1996. So it's right after this
That's right.
article came out. And last week, I just did my 112th donation, blood donation. So I had to applaud you. Yay.
We
Thank you.
applaud you. I mean, that's an amazing story. Amazing story. This is the letter from President Bill Clinton observing National Minority Donor Awareness Day in August 1, 1996. Uh, Something that has blossomed over time from a day to a week to a month. So it's 5 years now as being a month. This is designated by the United Senate and by the mayor of the District of Columbia. And this is an honor that most people are unaware of the fact that the Howard University Hospital is designated a research center in my name, and the Clive Callender Howard Harvard Surgical Outcomes Research Center with my picture on it, which has inside some of the tributes that I've received over the course of the last 40 years. This is one of my proudest moments with Dr. Sal LaFall being in front of the magazine, and they talked about saving lives with new organs. It was in August of 2000. Next slide. This is a slide of the National Minority Hall of Fame, which I was inducted to with many others. Sam Coontz, the first African-American transplant surgeon, Louis Stokes, and many others. Next slide will show 2001. Actually, LaFall and I were on the magazine front of the magazine together as the leading Black doctors, which is a single honor that I can always remember. This is when I did the transplant on Marion Barry, which was something that I'm proud of, and I'm happy that that's not the only thing people remember me for. But I was proud that Marion Barry was such a unique person that he could have been transplanted anywhere, but he chose Howard University Hospital and me to do his transplant. And so this is something that I shall always be pleased to share. This is something that few know that Alan Gibson did a transplant on him way back in the 70s. And his singing in the choir reminded me that it was something I should do as well. And so I joined the evangel choir to sing with him in the evangel choir. And this is something that was remarkable in many ways and something that I shall always be thrilled that I followed his lead in going back to singing again and continue to sing ever since. And this is something my twin brother and I put together two CDs. This is the first one, Songs to Inspire, with accompaniment by Alton Street, and has a 20, I think it's 22 songs. I do 20, Call does too. And there's old songs that remind you of the old days and songs that we sing, songs that we loved, and we still have these CDs to this day. And this is my favorite singer, Johnny Mathis, who actually retires this month after as he gets close to his 90th year. Uh, and this is a very great tribute that I was at the Stars of Life Walk of Fame during Life Float in 2009, where they saluted the work that I've done as a pioneer in organ donation. Next slide. And this is my family, actually, an honorary Doctor of Science conferred by Mary Medical College. Interestingly enough, I'm going to receive another honorary Doctor of Science May 20th of this year from the Brooklyn Downstate Medical College, which is where Samuel Kuntz, the first transplant surgeon, started the program there. And so anyway, this will be my fourth honorary Doctor of Science degree. And that's my family there. And that, can you go back to that one just a minute, just to show Elena, Ariane, Fern, and my son Joe, and the president, Wayne Riley, who just happens also to be the president of Downstate Medical College. Yeah. So anyway, it's a proud moment. This is at Meharry Medical College, 2008. Next slide, please. This is one of my medical students put together this Transcending Boundaries poster at the American College of Surgery, citing my work and Dr. LaSalle Fall's work, identifying the work of African Americans who may not have not been heralded before. And it emphasized our contributions to minority health, the fall in surgical oncology, and myself in transplantation. Next slide. And this is a portrait commissioned by the Department of Surgery and now hangs on the wall in the Department of Surgery at Howard University's hospital. Next slide, please. And this is me as a picture I took of me as a trailblazer in 2024. I was thrilled to be honored in that fashion. Thank you very much for doing this, John. And if there are any questions or comments, I'm open. Thank you very much.
Daryl, we need some applause there.
Thank you very much. Thank you.
Thank you, Dr. Callender, for all your contributions. Absolutely.
You are truly a blessing from God.
Thank you. Thank you. Thank you.
Yeah. Thank you very much, Dr. Callender. You are very inspirational. Thank you for your work.
You're welcome. You're welcome.
Well, you were in Nigeria from 1970 to 71. That was immediately after the war. Am I correct?
Right after the Civil War. Right after
Yes.
the Civil War.
How were you able to navigate entry, your group, into Nigeria? Because immediately I was living in Port Harcourt before the war. I lived in Port Harcourt most of my life when I was a teenager. How were you able to navigate your way into Nigeria immediately after the war? Because the government of Gowon was not in favor of missionaries getting into Nigeria.
Well, the Kaiser Foundation International recognized that Port Harcourt General Hospital had been virtually destroyed, and
Okay.
they agreed they would put together a team that would go into the Port Harcourt General Hospital and restore its
Okay.
capacity as a hospital.
Okay.
And so I'd always wanted to be a medical missionary, and one of my medical students was from Lagos, Nigeria,
Okay.
and right after the Civil War, let me know that there was a availability of me and my wife going to uh, Port Harcourt, Nigeria, to restore the Port Harcourt General Hospital.
Okay.
And so this is what I'd wanted to do since I was 7 years of age. So this is my life dream come true.
Okay. Thank you very much.
And it was only because
Mhm.
the fact that I lost 50 pounds during that 9-month period in 1970 that I decided to become a transplant surgeon after losing 50 pounds the first time and going back the second time, and then losing 25 pounds and
Okay.
contracting malaria. It was then that I decided I'd do my life's work in the United States.
Okay. Thank you. Thank you very much. Okay. Thank you for your good work.
Oh, thank you. You're welcome. Okay, I guess we can go to the next slide if there's no more comments, questions.
Yes, Dr. Callender, this is Elizabeth. I just want to say thank you. I guess it was destined that I meet you because I was offered several jobs at Meharry and I chose to go into another state. But thank you so much. When I'm at my book club, when I mention your name, I mean, I get rave reviews. So I just want to thank you and the opportunity to eventually meet you.
You're welcome. Thank you. Okay, let's go to the next one.
And just the ripple effects. I mean, we woo, talk about icon, talk about inspirational, about what one person can do.
Enough already.
You know, you know what one person can do with a good woman. A good woman behind him. You know what I mean? A good woman. You know?
Yeah, 56 years too. Can you imagine?
It's,
Yeah.
it's, oh, and I mean, talk about love story. All right? Love story. And I mean, this tremendous, and this is the story, this tremendous, you say global man who never learned how to drive, whose wife drove him everywhere. None of this would happen without Fern driving him. And after he did, and talk about a Christian, a man of God. After doing what he did all day, I mean, starting rounds at 7 o'clock in the morning, driven to the hospital by Fern. This
So true.
man, every time my mother was in the hospital, and she was in the hospital in New York, Clive Callender would have Fern take him to the trains to Union Station, take the train to New York, visit my mother, come back to DC, be picked up by Fern, and go home.
So true. So true.
Dr. Callender, you know, we all have stories, and I have so many. And I have to chime in, you know, I do. And with your wife, I did a note to her by way of the funeral home, the login for obituaries, because she had to have been a special woman to, I don't know if the word is allow you or tolerate the time that you've given to your patients. You truly have given a lot to my family, and I've thanked you over and over again. And being there with you and your family last week, I felt the love the same way as I'm feeling today, and all the accomplishments. You deserve the praise. You deserve the applause. And I can't thank you enough.
You're welcome.
Mhm.
All right, thank you very much. It's enough about Clive Callender. Oh, this is an article that my daughter and I put together, paying attention to 5 health conditions that may add years to your life. We all know about high blood pressure and the fact that it's a killer. Uh, what we aren't as aware of is that, in spite of our knowledge of this, the mortality rate from hypertension and cardiovascular disease has not decreased. It's still the #1 killer in the United States and the world. And so it's not enough just to know that you have high blood pressure, but you have to treat it and it has to be under control. And the goal is to get lower than 130/80, uh, because this can add years to your life. Uh, High cholesterol or hyperlipidemia, similarly, is a condition that leads to buildup of plaques and clots in blood vessels that may partially or completely block circulation, cause a heart attack or stroke. And blood test is available to find out if your total cholesterol is 200 or above. Your LDL or bad cholesterol should be less than 100, and your good cholesterol should be above 60. And so this is a blood test that everybody should get, so you know whether you need to take medication or exercise. And if that doesn't do it alone, then the medications, the statins, that actually lower the cholesterol level and increase your lifespan. Then type 2 diabetes is a condition that is very common in people of color over the age of 50. And the increased blood glucose levels is toxic to the arteries and causes arteriosclerosis. And this will cause a blockage of arteries in the body, especially at heart, brain, or extremities. And the way to know if you need this or not is to get a fasting blood sugar greater than 100 or hemoglobin A1C that is over 5 requires treatment. And normalizing the blood sugar may add 10 years to your life. So with a diet rich in fruits and vegetables with minimal to no red meat, uh, lifestyle modifications and medications may be necessary to achieve normal blood glucose levels, which is healthy and something that we've talked about in this group, and Daryl has talked ad nauseum for, for the last 5 years at least. Uh, more than number 4, more than 50% of men and women of color are obese, and we consider a BMI over 30 as obese. And now we have ways of treating with GLP-1 medications or weight loss surgery. And it's expected that if it's treated, this condition may increase your life expectancy by more than 10 years. And then smoking, of course, uh, this is something that's man-made. Smoking, which quitting smoking and normalizing blood pressure have the greatest impact on increasing life expectancy. So if you smoked up to the age of 50 and stop, whenever you stop, you can increase your lifespan. Other health conditions that we talk about that may not lengthen your life, but will certainly improve the quality of your life. Osteoarthritis is the most common form of arthritis. When your joint cartilages wear down and it's bone on bone, this leads to severe joint pain and severe disability. Uh, healthy weight, healthy weight and exercise treatments can delay the progression of arthritis and decrease the pain associated with arthritis. Osteoporosis, we don't talk enough about, is more common in women. 20% of the women over 50 uh, have it because of the fact that estrogen is no longer present. And there are normal vitamin D level, weight-bearing exercises and medications can increase the bone density. which can prevent the likelihood of bone fractures, which often leads to the death of people. Cancer, of course, is again more common in all age groups. So cancer screening of all types, including mammograms at least every other year, colonoscopies every 5 to 10 years, and prostate screenings are essential for women over age 50 to get an early diagnosis of cancer so it can be treated early and life saved. Good mental health and the minimization of stress are so good. Anxiety and depression are the most common forms of mental health issues. And at the age of 50, the immune system begins to weaken. Therefore, the double dose vaccines for flu and other vaccines, COVID, influenza, RSV, shingles, and pneumonia, are important to strengthen your immune system, which weakens considerably after the age of 60. So reaching the age of 50 is a blessing. Remaining in good health thereafter requires preventive efforts, including meditation and exercise for at least 150 minutes each week, eating a diet rich in fruits and vegetables, high in fiber and with limited red meat, drinking plenty of water, and optimizing your immune system and mental health. And this is the advice to all of those who are over 50 who want to live to be 60 and beyond. Floor is open for any comments or questions that you might have about this article that we shared with you. Any comments or questions?
Constance, do you know how to mute your phone?
Oh, okay. I'm sorry.
Yeah, it's coming over real loud. Thanks.
Fabulous article. Fabulous article. Look, it should be going over social media. You know, it's what we need. It's outstanding. Humble man of God.
Thank you. Thank you. Next article, please. No, any other comments or questions?
I have a question before we go.
Okay.
On my evaluation from my primary physician, the term
Sclerosis?
Athero or arteriosclerosis,
I wanted
which
to know
means hardening of the arteries. And when we talk about the cholesterol results in deposits in the blood vessels, which are very flexible. But when you get this hardening of the arteries, it then leads to blood clots, which can cause strokes and heart attacks. And so by normalizing your blood pressure, keeping your cholesterol normal, you can try to decrease the amount of arteriosclerosis in addition to the exercise and the plant-based diets that are recommended. And those are the ways in which you can reduce the amount of arteriosclerosis.
So
any other comments?
My question though, is there a difference between atherosclerosis and arteriosclerosis?
No, they're the same.
Same. Okay. Thank you.
Yeah. Betty, you had a comment?
Yes, good morning, everyone. I just wanted to make a comment about, you all have heard me talking about my losing weight, but I just want to do a shout out to my husband because he just had his, he's a diabetic and he goes 3 months to his doctor. And when he went to his doctor last week, he had lost 13 pounds. So, and that's because he has to follow me because I'm the one doing the food and getting it together. And he has lost weight because of it. And all of this is because of one of the articles that was shared during one of our presentations.
Great news. Wonderful. Congratulations to you and your husband. Yeah, congratulations. Hats off to both of you.
Thank you. He's telling me A1C is 6.15.
That's wonderful.
Yes,
That's fabulous. That's fabulous.
yes.
That's wonderful. Oh boy. Great news. Great news.
Good.
Great news.
I
Keep
agree.
up the good work, Betty, as well as your husband following your leads.
He doesn't have a choice.
Well, keep on keeping him alive. Okay. Any other comments or questions about this article? If not, we'll move on to the next one. Uh, no surprise, ultra-processed food consumption, thanks to Kennedy, is right in the front light, and the emphasis on preventive medicine couldn't be better because ultra-processed foods plays a large role in this. And so the one thing about Kennedy being in charge is that the focus will be on decreasing ultra-processed foods, which is something that is very good for the country. Uh, we've talked about it for many years now, but I think with his leadership, this is something that's positive that should help the health of the country. There's a little reluctance to admit the fact that this plays a large role in our all-cause mortality in this country because we have so much reliance upon the ultra-processed foods. Any comments or questions about this article that emphasizes something that we've discussed for quite a while with Darrell Armstead leading the charge forward? No comments. I guess everybody's so used to hearing about it that they, anyway, so one good thing from Trump's takeover is Kennedy emphasizing how important preventive medicine, preventive health is, and addressing the ultra-processed foods and the is a positive. Okay, if there's no comment or question, we'll move to the next one. This is an article that talks about I missed Lucy. You had a comment.
I was just going to say that I hope with our knowledge of that, just as we are discussing here, and Sister Betty, hands off to you. They say that if you teach a man, if you can give a man a fish and he'll eat for a day, teach a man to fish and he will be able to eat forever. But if you teach a woman, she will educate a and so hats off to you for what you've done for your husband and the ripple effect I know it's happened. And again, with the processed food, the equity, where do you find processed? Where do you find fresh whole foods most?
Where we live, where we live,
Mm.
where people of color live. That's one. That's one of the issues that they call them food islands, in which finding a place other than fast foods is difficult for most people. And you find plenty of places where people who are economically prosperous. I mean, you have many locations for them, but locations where people are socioeconomically less fortunate, uh, they are bombarded with the fast foods, which are the ultra processed foods, which lead to uh, higher mortality rates. But sharing this information in the fashion that you mentioned is something that's very desirable, and educating and empower the community to eat better is something that we can do, and also uh, there's no limit to how we can help one another in that capacity, especially with our children and grandchildren, if they'll follow the lead that you've demonstrated. Any other comments or questions about that? Not, this is a non-invasive spleen test that allows you to identify liver disease without any of those radiation tests that cause other complications. And this is a test that has just now identified spleen stiffness as uh, as a causative factor for liver decompensation, which will then result in chronic liver disease. This is not yet widely available, but because of this new finding, it may well result in us not needing to do so many x-rays of the liver, but actually using it. And as you recall, last week we talked about an EKG finding that identified liver disease. Now you have a non-invasive test that will also predict splenic stiffness that is associated with liver disease, which now is treatable with some of the GLP-1 drugs. So we're coming a long way, although this is early on in terms of studies just showing that this can pick this up. Hopefully, this will lead to fewer X-rays and other ways of, and we do have ultrasonic ways of identifying liver pathology anyway. So the need for X-rays to identify liver pathology is no longer necessary. Any comments or questions on this new development? Remember the article last week talked about the fact that CAT scans are important, but they also have an increased incidence of association with cancer. Not huge, but enough so that when you can avoid a CAT scan by other therapeutic modalities, then you should. So that's why we included that article. Then RSV is the vaccine that we all are aware of, but I think more recently, uh, while we knew that above 60, it was increased cost of death, it has also increased death for over 50. And so the age at which it's recommended to be given is now 50 and above, rather than the 65 and above that it was formerly. And so keep this in mind so that your children and grandchildren can understand that while they're not as old as we are, they still are old enough to be able to take advantage of the RSV. It does have its side effects, but they're relatively minimal compared to many of the other vaccines. I assume most on this call have gotten RSV vaccine. If they're over 50, they should. Any comments or questions about RSV? RSV just became available this year, well, 2024. Before then, there was no RSV vaccine, so this is brand new. This is an interesting article that, pardon me, that asks, can curing infections help prevent cancer? Actually, it might say, can curing viral infections help prevent cancer? Because all of these infections they're talking about are viral infections. And they'll go back to pylori as a bacteria. The rest of them are viruses. Papilloma virus, the hepatitis B virus, hepatitis C virus, uh, and the HIV virus. So that if you prevent these infections or treat these infections, this article suggests that this is one of the ways of decreasing the incidence of cancer. H. pylori being treated can decrease the likelihood of gastric cancer with the HPV, penile cancers, anal cancer, and oropharyngeal cancers are reduced. And with the HPV, hepatitis B and hepatitis C, treating them will decrease the amount of liver cancer. So this is something that is perhaps very true, that by taking these vaccines and by decreasing these infections, the one bacterium and the other viral infection, you simultaneously are in decreasing the incidence of cancer. So another reason why you should take vaccines. Mr. Tatum.
Yeah, can you remind me of the two types of liver diseases? One is viral, and what's the other?
Oh, you're talking about well, of course, alcoholic hepatitis and uh, steatohepatitis, which is related to the fatty dystrophy of the liver that kills the liver cells. So steatosis, which means fat, and the alcohol, and then of course the HP, hepatitis B virus and the hepatitis C virus. And we now have treatment for them. Dr. Perez?
I think this brings up the very important point. I know you gave kudos to the Secretary of Health and Human Services, but we know these things, and and we know the consequences. And we know that if we make the vaccines available to everybody in an equitable fashion, we save money on the other end. And that's not what we do. That's not public policy. Why isn't RSV available as a vaccine to everybody over the age of 50? I'm just saying, I'm just interjecting that into the fact that we see that people have impact on policy. And we see that people are taking to the streets to address the egregious policies that are coming out of the White House now. We cannot allow it to go without addressing these inequitable policies as well.
Well, I think balance is very important, and I think your points are well taken, that this is not a standalone. This is something that is going along with policies that are reducing or eliminating Medicaid, Medicare, and things that help people of lower socioeconomic levels. And so having things that are given equitably would be important, but that is not the case. And I think the balance that you bring to the table by bringing out those points are very important. Dr. Atto?
Yes. Yeah, thank you once more. I want to know if there's any major difference between spleen stiffness and splenomegaly. Any major symptomatic difference between spleen stiffness and enlargement of the spleen?
Well, I think splenomegaly is not necessarily stiffness.
Okay.
Stiffness is a different aspect of the equation because you can have a large liver without having a stiff liver. And so I think splenomegaly is different from splenic stiffness, which is what the question that you asked. Does that answer your question?
Yeah, but if somebody has, enlarged spleen, how can you differentiate it from a spleen stiffness?
Well, they say that this test that they're doing would differentiate between stiffness and just a large spleen, because what they're looking at is the stiffness of the spleen, not the size of the spleen.
Okay.
Whereas splenomegaly, the large spleen, doesn't
Okay.
have to be a thick spleen.
Okay.
And splenomegaly is not necessarily associated with liver disease, whereas splenic stiffness is.
Okay. Okay. Thank you.
John Buchanan?
Yes, Dr. Callender, are you aware of one of the Black scientists at the NIH whose research on H. pylori was groundbreaking? Were you aware of that?
No, you want to tell us about it?
Well, I've forgotten everything I learned about it, but it was quite a while back, probably 20 or 30 years, maybe 20 years ago. And he was on the faculty at NIH and brought this out. H. pylori, I think, was associated with
Ulcers.
ulcers. Yes,
With ulcers.
yes.
Ulcers. Yeah, at the time, everybody thought ulcers was related to acidity in the stomach. But they pointed out that that is not the case. We were actually doing surgery for uh, ulcers at the time. And when the treatment for ulcers is now uh, antibacterial medication that kills Helicobacter pylori. And this was a major change. Uh, Here we were operating on a condition that actually could be treated by antibiotics. And this was a major drastic change that occurred about 30 years ago, as you pointed out. And it was night and day for surgery because now we very uncommonly do uh, operations for gastric ulcers because I'm sorry for stomach ulcers because stomach ulcers now we know were caused by a bacterial infection and now can be treated by medication. So thank you for bringing that up. I don't know the doctor's name who made this dramatic finding, which was really ground shaking and earth shaking at the time.
I'm going to try
Mr.
to look.
Tatum?
I'm going to try to look that up. The name of that science.
Okay.
And also,
Good.
I remember my father was hospitalized at Bethesda Medical for ulcers, and they did the surgery on him as a result of that. So had this discovery been made, he could have saved a lot of time in the hospital. Thanks.
Yeah, many had surgery for an ulcer that was actually caused by a bacterial infection. Mr. Tatum.
Yeah, my other question had to do with one organ disease being viral, and that same organ has a disease that's bacterial. Can you speak about an organ being diseased by way of virus as opposed to being diseased by a way of bacteria? like
Well,
meningitis.
the only organ that they talked about that is affected by bacteria was the stomach, Helicobacter pylori. The rest of them were viruses.
What about meningitis? Can that be viral and or bacterial?
Meningitis.
Well, yeah, it can be either.
Right.
Right.
Okay.
Right.
Exactly. Other
So,
organs can be like that too, one or the other.
well, there are probably many organs that can be affected by bacteria and virus, but I think that the meninges is affected by both, and uh, of course the lung, of course, is affected by both, and uh, there's some evidence that the GI tract can be affected by it, though. But
Because back in the day, um, the question came up about my liver disease, whether it was viral or bacterial.
liver disease can be affected by both, yeah, viral and bacterial.
And I never, I
But
think,
predominantly the most common are the viruses
okay.
impacting the liver.
Mhm.
Yeah. But there are parasitic involvements of the liver as well as bacterial involvement of the liver by secondary infection. Yeah. Okay. The next slide, the next article rather, talks about BMI being important, but more important than BMI is actually weight loss. And sometimes this article is suggesting that we put so much emphasis on BMI that we forget about just having patients to lose weight, which would be helpful as well. Whether they reach the target that they want to reach is one thing, but uh, decreasing the weight will help with the fatty liver disease. It will help with blood pressure, and even help with obstructive sleep apnea. So that whether or not you reach your target, they're emphasizing that our emphasis should be on trying to get people to have a healthier BMI and healthier weight. And whether you reach your target or not, emphasis on losing weight should be individualized and should be emphasized. Any comments or question about this article, which I think is an important one? But sometimes we make so much emphasis on losing 20% of the body weight that we sometimes don't emphasize appropriately enough that getting started and losing uh, weight will help in your overall health.
Dr. Callender, the GLP drugs, are they more effective with weight loss or are they more effective by bringing your BMI in order?
What is your question?
The GLP drugs, do they help with your BMI or do they help with more so with weight loss?
They help with both. The one thing that they do is that they help you to get to the target of weight loss faster than many other things other than bariatric surgery. So that GLP-1 drugs play a great role in improving overall health as well as reaching the target of the desired weight loss that you need to have. Any other comments or questions about this article? Kind of common sense here. Okay, this is something that I emphasize because I realize that most people over 50, when they go get their health exams, do not get a urine tested for protein. And we now know that the earliest sign of kidney disease is proteinuria, albuminuria. And uh, all of you who are over 50 who go get your annual physical should insist that your doctor test you for urine protein because it's the earliest way of finding out. Many people who go to the doctor get a urine test are positive for albumin, but they do nothing about it, and that's a mistake. And so I want to emphasize the importance of this kidney disease screening, which can allow you to detect kidney disease in its earliest form and get you to prevent the kidney disease from turning into end-stage kidney disease, which it can if it is ignored and nothing is done about it. Since we do have ways now of trying to reverse early kidney disease uh, uh, by medications and other means, so it's important that you learn. Sometimes some people come in at 50 with proteinuria and nothing is done about it. And at 65, they find out they have chronic kidney end organ kidney disease. They need dialysis or a transplant. And so this is something that could prevent that from occurring. Any comments or questions about this important article?
Dr. Counter, you know what my question is. I don't even have to ask it, right? How much is this test going to cost?
No, it's next to nothing.
Okay, all right.
It's very cheap, very cheap. Maybe about 50 cents.
Wow.
So it's not anything that's going to increase your medical costs. It just may save your life, keep you from dialysis or transplantation. So all of you, if you're over 50 and you go to your doctor, be sure that they check your urine for protein. And if you have protein in the urine, then the follow-up becomes critical.
Is this going to be
Sometimes foam in the urine is a first manifestation of urine protein.
is this going to be over the counter, you think?
This is over the counter, yeah, urine protein screening, but it's done. It can be done by you just give them your urine and they can do your test for you. But yeah, you can get it over the counter. Okay, the next article, please. This is an interesting article that talks about the fact that in some instances, urine is not sterile and can cause stones. This is something that is little known. Most people know about the calcium oxalate stones and the other stones, but they don't know about the fact that bacteria can cause stones as well. Uh, this is something that, for the most part, is little recognized, and so we all know about the fact that there and we all know about taking cranberry sauce, cranberry juice can change the acidity of the urine and make you less likely to get some of these stones. But little is known about the role of bacteria in stone formation and how treating with antibiotics may prevent some of these stones. We know that kidney stones is one of the most painful conditions known to man, and that some antibiotics may prevent these stones from being formed.
Dr. Callender, my question would be, if you did get a kidney stone, how do they get rid of it?
Say again, I didn't understand the last part.
How do they get rid of a kidney stone?
How do you get rid of them? Is that what you asked?
Yes, yes, sir.
Yeah. Well, you can have surgery to remove it. They also have a lithopexy uh, uh, by radiation, X-ray treatments, but they have a way of crushing the stones by way of X-ray treatments, as well as actual go in and surgically take out the stone itself. Since it's one of the most painful conditions known to man, and I think Janice talked about it last week, it is important to recognize that the pain is so acute that you need to go to the hospital for the most part in order to get it treated. Janice, you're on mute. Can't hear you.
Yes, I was going to say the same thing. My sister experienced it several months ago. She was having this tremendous pain and she didn't know what it was. And she had passed a stone. And months later, it turned out she had more. And they were going to let it run its course. She said it was so painful. Do whatever you have to do to get rid of it. And they did some sort of laser procedure, and it was in and out. And apparently, they crushed the stones through this process. And I guess she was able to release it in smaller bits or whatever, much smaller pieces. But it was nothing like the first experience. So she said it was worse than having a baby.
That's pretty bad.
Yeah. Mm-hmm.
Any other comments about kidney disease and the new association of bacteria as a cause of stones? Let's go to the next article now, please. Actually, we have to give kudos to John Buchanan, who prepares some 20 to 30 articles every single week so that we can look at them and discuss them. So kudos to John Buchanan, who does this every single week without fanfare. So let's all salute him. Now, this is an article that talks about kidney function assessment and chemotherapy. I mean, uh, there's been a lot of comment made by some of the people here who have recognized that the EGFR creatinine clearance measures have been modified so as that whether you're black or white, the findings are the same. But at one point, we had a different status because we were black and had more muscles. And so this has been changed, but this is now recognized as being critical in giving the right amount of chemotherapy. Because if you don't give too much chemotherapy, you can knock out the kidneys and the heart. So they emphasize the importance of doing correct GFR estimations and kidney in patients who have cancer so that you can give them the right amount of chemotherapy. Because there are conditions where the chemotherapy can knock out the heart, it can knock out the kidneys, it can do other things. So it's important to do a formal creatinine clearance, which by the Cockcroft-Gault equation, which is more accurate than what has been done before. It's particularly important for people of color to be aware of it. You can see this association that 6.5 likelihood of developing kidney disease and 3 times higher for death if you don't get the correct creatinine clearance and get the proper dose of the chemotherapy. Okay, if there are any comments, go ahead, John. You can.
Yes, Dr. Callender, how is chemotherapy administered?
Intravenously most of the time. And then there are many side effects of these chemotherapeutic agents, which certainly kill cancer, but they also can give you side effects, many side effects, most of which are not lethal, but some of which are. But I think there was a lack of appreciation of the importance of the understanding of the price you pay for overdosing people with GFR because you haven't gotten a proper estimation of their kidney function. Let us then go to the next article, please. This article is not dissimilar to the other one we had that emphasizes that weight loss strategies should be just that and not quick fixes. You don't want to just lose weight for 3 months and then gain it back. You want to have something that improves your health and keep it off. And so the emphasis should be on doing it all: dietary, hydration, physical activity, weight resist, incorporating resistance training, and also sleeping appropriately. So it's the whole ball of wax rather than just a simple part of it. Certainly, the GLP and the bariatric surgery are important parts, but they are parts, not the whole thing. And this is what the strategy should be all about. And that's why, even before the bariatric surgery, they go through psychological and other strategies to talk about the way your healthy lifestyle or lack of healthy lifestyle and how you adopt a healthier lifestyle so that it's not a quick fix, but a weight loss strategy that is enduring. Any comments or questions? If not, let's go to the next article. This is one that is surprising, that the childhood antibiotic use is linked to increased risk for asthma, food allergies, and intellectual disability. And this is a study that is frightening in some respects because there are so many children exposed to antibiotics uh, within 2 years of birth. And I don't know that we were aware of the complications that occur as a consequence. And here you have them, as you can see, asthma and food allergies and especially when they're compared to sibling match who didn't have antibiotics. It's kind of surprising to see that.
Dr. Callender, do we know what the most common use of antibiotics in the first year of a child would be? I mean, for me, I remember was ear infections seemed to be a lot, but is there a common theme that why antibiotics are used so routinely in kids that young?
I go to the top, but this article did not talk about that as much. Let me see what it says here. It talked about the use of it, but it didn't say why they were used.
Yeah.
And that's a good question. I think the commonest thing I hear is uh, 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 air infection, but upper respiratory infection could be increased as well. Now, the question is whether they should be used for URIs. I think not. But we got a pediatrician here. So, Dr. Perez, you want to answer that question?
I think it also speaks to what we know and the importance. Definitely ear infections, URIs, but getting children immunized so that we know the distinction between whether we have an infection or infections that can be prevented.
Mhm.
So many start out the same way. We have an epidemic that's going on with measles, which is egregious. And to move away from immunizing children so that we don't have to worry about them. It is estimated by the time that we get to 2030, I thought it was 2030, but it might be 2050, that infectious disease is going to, in death, is going to outrate cancer deaths. So worldwide, we have got to be about immunizing, making sure that those infections don't occur.
Absolutely.
And everything that we know about healthy food, nutrition, all that stuff, and giving it to those that are at greatest risk. I would say for me, it was definitely upper respiratory infections. And that's why RSV is so important in old people, so that we can make sure that we don't transmit back and forth between young children and more mature people.
Thank you
So
for sharing. Darrell?
Okay, I'm glad I got some pediatricians on the panel, not doctors and nurses, um, because it seems to me a little bit that antibiotics and fevers may be working at cross purposes. And the reason why I say that is that antibiotics can lower body temperature. Fevers generally, um, that's the sign that the body is, that the immune system is working. And that the body is being effective in combating the infections. So, I'm thinking that, we know that antibiotics need to be prescribed judiciously. There's some diseases, some infections where you absolutely need to have an antibiotic, but there's others I would think, but you tell me. There's others I would think that you're better off without the antibiotic, just letting the body fight it through fever. If the fever is not dangerous, just let the body do its thing. So, what do you think?
I agree. The problem has been that so often people wanted antibiotics for viral infections, and not having continuity of care or access to care. Many physicians gave antibiotics because they didn't know whether they have the opportunity to see that child again. So when we have adequate access, you would be able to tell whether or not you were dealing with something that was bacterial or it was infectious, or it was viral. So giving an antibiotic became the default posture when you weren't sure. Now, with appropriate access to care, you can make the distinction as to whether you're dealing with a viral infection or whether you're dealing with a bacterial infection. And an antibiotic for a viral infection is ineffective. Does that answer your question?
Well, I think that's a good answer in the sense that if you have a bacterial infection that's causing fever, you need to give antibiotics. On the other hand, if you have a viral infection that's causing fever, the treatment is not antibiotics. And I thought you quite accurately described the difference. The problem is that without equitable access, uh, some people, some physicians just treat empirically with antibiotics, and that is a mistake, which the side effects are what you see here. And so you have to, in other words, you need to give antibiotics where bacteria are the cause of that fever. When that bacteria are not the cause of that fever, antibiotics can cause more harm than good. for viral infections, which do not require antibiotics. And that's the issue of 2030 and 2050 when resistant organisms develop and prevent us from being able to treat infections at all. A lot of these are consequences of the inappropriate use of antibiotics when there is no bacterial infection. That's part of it. Patty DeLone, do you have any other comments you want to make about it?
I think that's probably true. I think for a busy pediatrician, it's probably easy to prescribe an antibiotic and the fever may go away and or it may not. But I think the parent gets a sense of uh, security if there's some medicine the baby is taking, um, more than just kind of waiting it out. So it's probably true. I would agree with that, Dr. Callender.
And I have to say, at this point, we need to have access. So many people say go
Yeah.
to urgent care.
Yeah,
Go to urgent
exactly.
care. You're seeing somebody who doesn't know the child, doesn't know the family. You know, when I was in practice, I mean, I had a morning call where people, I had my coffee, mothers would call, being able to speak to somebody. This is what I see. I know you. I know your child.
Yep,
But we don't have that now.
true.
Go to urgent care, see somebody. You don't know.
Hmm.
The urgent care issue is one that is disturbing me more and more because I encounter so many people who recently who've gone to the urgent care and come back and died at home. And so that sometimes the going for the quick fix may not be the complete answer. So it's food for thought. Any other comments?
What about tetanus? Would that be
What about what?
tetanus? When a little child stepped on a nail or something, is antibiotic recommended for that?
I didn't understand the word. What word did you use?
Tetanus.
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 Okay,
Well,
but,
tetanus is okay. So we have immunity for tetanus, so that theoretically, if you take a tetanus shot, you wouldn't need that kind of treatment. But if you have not had tetanus shot, then of course you need the treatment. But the treatment of choice is the vaccination for tetanus. So
DPT.
uh,
It's usually DPT,
when I
right, to
went to
get
Africa, the commonest disease was tetanus
Mm.
yeah.
because they didn't have the vaccine.
So
So
question,
that
is that a viral or bacterial infection?
bacteria.
The bacterial, yeah.
Carol, you had a comment.
My comment is usually the same. The only reason people go to urgent care because you can't get a hold of your doctor and he'll tell you come back. I can see you in September when you want urgent care right then and there. There are very few doctors like you and Dr. Perez and et cetera that are on this board. They no longer see us. And then when every time they see you, they gotta look at their computer anyway to figure out who you are. And then put notes and they ask you the same questions before that they ask. And I don't expect them to really remember me, even though I might make myself known. But urgent care came out of a need because I guess there are fewer doctors and even your personal doctor, unless you're just telling them, I'm just flat out. They say, go to emergency room. They tell you to go. Don't you? I can't see you right now. Go.
Well, but so why don't they go to the emergency room? The problem is because of the long waits in the emergency room. But that doesn't mean they shouldn't go to the emergency room. For some conditions, urgent care is not the answer. For some conditions, emergency rooms are the answer. Because if you're very sick, you need to go to the emergency room. If you're very sick and you go to the urgent care, they may not be able to handle you. So your comment is well taken, but one of the uh, real issues is the long waiting time if you go to an emergency room. And that is what turns off a lot of people. If they fear that if they go to the emergency room, they're going to have to wait hours before they're seen. And that's the real turnoff. The urgent care centers is really for those people who aren't very sick, who have problems that can be addressed quickly and fixed quickly. But if you got a chronic problem or you got a severe pneumonia, the urgent care place is not the one that's good for you.
If your doctor won't see you when you have an emergency, you probably need a new doctor. Because if you're going once a year for an annual visit, your doctor should know you, be aware of you. And they have a lot of nurse practitioners working with them now who will see you urgently. They might have you come in a back entrance that doesn't sit with the people waiting who are healthy, or that you can communicate your condition with them. But I think if you have a doctor who won't see you for an emergency, you need to look for another doctor. Sorry about that.
But I also have to point out that when we go back and we look at compensation, all right, in terms of what is no longer compensated.
Yeah.
Talking to a young mother about breastfeeding. Now we have breastfeeding experts, but we won't compensate a pediatrician for talking to a mother about breastfeeding. So we have started something that has an effect. You said nurse practitioners. Why not compensate the pediatrician?
Yeah.
Okay, we've developed a whole new system that quite frankly, many we're up to 70% of new physicians. I think it's even higher than that. That is about 10 years old that are employed by healthcare systems. So they don't control who they see or when they see them. When you go into the hospital, you are no longer followed by your doctor. You're followed by a hospitalist. Why? Because they feel that is cheaper.
Yeah.
Okay, so when you are told by the people who employ you that you have 7 minutes to get in the door and out the door for seeing a patient, that's not good quality care.
Agree.
Okay, thank you. Daryl?
I got to support Dr. Tatum for her comment about how hard it is to see a doctor. I moved 3 years ago, and it took me. I found another doctor, but it took me 6 months to get an appointment with this new doctor.
Wow. Well,
Is your health insurance Kaiser?
well,
You
this
said
is
what?
a dilemma that I think is killing people. And so
I asked I asked for professional courtesy. I am an old lady with type 2 diabetes, and it took me 6 months to see an endocrinologist.
that answers the question. Yeah, that's the problem. That's the problem. And
I,
our healthcare system needs a lot of help. And actually, trying to get into the system is, as you mentioned, Daryl and Carol, is a problem. But the question is urgent care the answer? That's what I'm saying. That the quick fix may not be the situation for all ailments. For some, it may be, but for severe ailments, uh, being willing to wait the time in an emergency room may be part of the answer. But our healthcare system has failed us. That's one of the recognitions that we have to admit. When it takes you 6 months to get to see an endocrinologist and you're a healthcare professional yourself, and then Daryl has to take 6 months to see a doctor, that answers the question. That's the problem. And how do we solve it? I don't know the answer. Betty Baylor.
yes, I want to talk about the urgent care. Just like you all were saying about going to the emergency room, you have to wait so long. And I guess people have decided to go to urgent care. Well, my husband and I sit in urgent care for about 8 hours. So it's
Oh, really?
not as bad.
Wow.
It-
Not
Oh,
so
no.
it's
urgent.
getting just as bad, is what I'm trying to say.
Wow.
Okay. Well, in my
Wow.
neck of the woods, I can get into urgent care within the same hour that I need it. But on the other hand, I know some people who have waited in the emergency room all day. Well, literally, there was
Yeah.
a lady that I know. It took her mother to the emergency room, and her mother was having a heart attack. They didn't recognize the symptoms. She sat there in the waiting room for 8 hours and died in the waiting room.
Yeah. Well, yeah, I think that there are horror stories from all sites, and of course that is inexcusable. Uh, but what we're talking about is a healthcare system that's failed us, and the question is how do we restore it? And it doesn't seem to me as if we're going in the right direction. Although I recognize the importance of emphasizing preventive care, uh, one of the problems is that we're so far behind with our preventive care that our people who are sick are not taken care of very well. And I think the points that you raised just point out the deficiencies of our healthcare system. And the question is, how do we fix it? That's
Dr.
the that's
Stone, I
the
think we're going to have to go start seeing robots.
okay. Well, that's a possible fix, but robots alone is not going to fix it. Uh, the combination, I think, will be fixing. But one of the things is what we're doing now isn't working. So we got to find another way of doing it. So, and Trump is giving us another way. So.